Good morning. My name is Elaine Eberhardt. I'm the Chair of Development at Mayo Clinic in Florida, and it's my privilege to welcome you today to Behind the Shields and to an event where we'll hear some wonderful speakers today. This event is to honor several groups of benefactors, and I thought I'd start out by seeing if we have some of those groups here today. What about the Doctors Mayo Society? Do we have members of the Doctors Mayo Society here today? Dr. Graf Radford is a member of the Doctors Mayo Society. I'm a member, Geraldine is, Geraldine Perugia, I am. And so that group are benefactors who are physicians, alumni of Mayo Clinic, or administrators who contribute each year. How about members of the Mayo Legacy? We have several members of the Mayo Legacy. Mayo Legacy members invest in the work of Mayo Clinic through their estate plans or through other planned gifts. We also have members here today of the Mayo Clinic Leadership Council for Florida. Would you raise your hand so that we can welcome you as well? Thanks so much. This is an exciting time to get together. We're coming to the end of our campaign for Mayo Clinic. The campaign was called You Are, the Campaign for Mayo Clinic. It was a $3.5 billion campaign, and it will conclude on December 31st, 2017. And we're hopeful that it will be successful, and we're optimistic about that as well. The campaign has many funding priorities, but the main goal is to increase hope and healing for all of our patients. Many of you have already participated in that campaign, and we're deeply grateful for your support. As you listen today to the presentations, please know that you're an important part of all that we do here. Your philanthropy makes it possible for Mayo Clinic to offer new treatments, cures, and hope for all who come in the doors here at Mayo Clinic in Florida and across our enterprise. Today we're going to begin with a presentation by Sarah McLaughlin, but just a few housekeeping details before we begin. The restrooms, as you may know, are right outside the doors to the Kinney Auditorium as you go out on your left. We will have a break after the third presentation, but if you need to move about during the presentations, you're welcome to do so. You also maybe behind the notepad, and there may be some on your table as well. If you up so you can see. If you will write questions that you have for the speakers during the presentations, Sarah and others will collect those, and then we'll use them during the question and answer that will follow each speaker. Now it's my pleasure to introduce Dr. Sarah McLaughlin. Dr. McLaughlin is Medical Director of the Robert and Monica Jacoby Center for Breast Health. She's a renowned surgeon and researcher, and her research focuses on causes and prevention of lymphedema, which is a common and painful side effect of breast cancer surgery. We appreciate you joining us today, Dr. McLaughlin.
Thanks so much, Elaine. Thanks for having me. Welcome to the Mayo Clinic. Okay, should I use the mouse or will this work too? Let's try the mouse. All right. Yeah, keyboard's fine. Okay, so you know, I kind of put together a wide variety of topics by nature. I am a breast cancer surgeon, so certainly a lot of this will focus on breast cancer, but I also wanted to kind of give you an overview and highlight some of the other things that are going on in our cancer program here. So I think when we think about cancer science, this is what a lot of people think about. And I promise you there are many, many other way smarter people than me in the lab who are working on this kind of data. This, it's a really nice kind of grid that's mapping out and then this is how we do a lot of drug development and a lot of ways to try to identify why some patients get cancer and some don't. But when we really break that down, and the patients sitting in my office, they don't understand those kind of heat maps, just like I don't understand those heat maps, and I can't explain them very well. What the patient really wants to know is, what does that mean for me? And so when we think about that and we start to try to understand that, this concept is being talked about as a lot of different things across the medical field. And is it personalized medicine? Is it precision medicine? Well, at the Mayo Clinic, we choose to call it personalized or individualized medicine. Because this is what happens, right? You're sitting in the chair and you really want to know from the doctor, what does that mean for me? What about me? What does this mean for my cancer? So one of the things that we do very well at the Mayo Clinic is this multidisciplinary approach where we engage many different specialists, many different activities all at one time to try to get really the best response and the best answer for each individualized patient. And this is something that I'm very proud of. I think that this is something that distinguishes us and sets us apart. Although a lot of people talk about we do this at our organization and whatever, at the Mayo Clinic, we actually really live this. And that's evidenced by our medical record, the way that's set up, our multidisciplinary conferences, and the interactions, the collegial interactions we have with our fellow colleagues and team members. Certainly, when we think about this individualized medicine in the era of ever-changing research in the cancer landscape, we think about this as drug development. Did we identify a gene? Have we identified a drug to match with that gene? Can we personalize it from that perspective? And certainly, we've done that in breast cancer. This was one of the early studies that we did where we looked at high-risk women, women who have really bad breast cancers. Can we identify specific genes that might find a subset of women who are at higher risk for the cancer coming back? And then can we offer some additional therapies to try to prevent that from coming back? So I think that's what a lot of us think about when we think about individualized medicine. We've also done that in lung cancer, for example, and in colorectal cancer. So this is not unique to the breast cancer landscape. But I think where we're taking individualized medicine is in additional directions. And one of the big hot topics these days is immunotherapy, and specifically looking at vaccines, both for prevention of recurrence, but also for prevention of the cancer ever developing in the first place. So in the breast cancer world, we do have a vaccine trial where patients with a very aggressive kind of cancer or a more aggressive kind called triple-negative breast cancer go through the standard treatment. They then can get a vaccine within a year afterwards, and that's supposed to help augment their own immune cells to fight the cancer from coming back. So what better way than to take what you already have and see if we can't bolster that? In addition, there's immunotherapies for patients who have more advanced disease, metastatic disease. And then even in prevention, one of my colleagues is looking at probiotics as a way to harness the gut flora that we all have and see if that doesn't harbor a better immune response and ability to fight cancer and prevent cancer. So we see very aggressive and radical surgeries when patients have, say, colorectal cancer that comes back on the lining of the abdominal wall. We see that also with some stomach cancers and ovarian cancers. And historically, that has been uniformly deadly. These patients die from this, and there's been no treatment options. So what he can do is he can go in, actually take out all of that tumor that's on the abdominal wall, but there's still very high rates of complications and questioning whether or not these patients actually will do well with this treatment therapy. What he does then is he closes up the abdomen. This is the most gruesome picture that I have, sorry. But these little tubes here that you see, the red ones at the end and these white ones in the middle, the white ones are actually instilling heated chemotherapy into the abdominal cavity that then gets shaken around for probably 90 minutes or so and then taken back out, and then he goes in and finishes the surgery. So that's kind of where things had been. What he did was he actually went a little bit further and said, what if I look at the immune response in the abdominal wall and then try to categorize how well these patients do? Can I predict who's going to do better and who's really going to respond? And so what you see here is when he actually labeled his chemotherapy with one of these immune drugs, you see a significantly better response here. The graphs over on the left there, the taller bars mean that those patients responded that much better than the patients who didn't get the immune drug in couple with the chemotherapy response. So that's a really big deal. That's a significant difference. And then he was able to demonstrate that under the microscope, that he actually could see a difference in the immune responses in the abdominal lining of these patients who got these drugs compared to not. So clearly there is an opportunity here that's perhaps starting to be more recognized, that wasn't previously recognized, that is going to improve the way that we're able to treat many different cancers. Some of their work has been very effective in the fact that they've been able to simulate this. We have a great simulation center. They've been able to use that to try to help predict what might happen, but also to practice how this might actually work in a patient environment. So that's been very helpful from the team standpoint to figure out how to operationalize this in the operating room and everything else that needs to be done. But I think it's really important for us to remember that individualizing cancer care is really a lot more than just the treatment. It's a lot more than, did you just get the right drug, or should you get a different drug or anything like that. We really have to go back and understand our individual genetic risk. We need to look at this from a standpoint of high-risk screening and prevention. Maybe everyone doesn't need to be screened the same way regardless of what the cancer is. Maybe there's a risk assessment model. Certainly in breast cancer, we have 3 or 4 different risk assessment models that can predict breast cancer risk, but the problem is each one of the models is different, and what goes into each one of the models and the value that you get out is a function of the variables that you looked at when you tried to adjust that risk. So it's not straightforward. And then we want to be able to correlate some of these benign findings with what we see on images, maybe avoid some biopsies. So if we look at screening, and now kind of get into a little bit more of the breast cancer world, screening can actually be really confusing for a lot of patients. Everyone's risk is not the same. How do you figure out what your risk is? What's the input of your family history here? Do you have any symptoms, any genetics? And then there's this big piece about the media, right? Especially in breast cancer, the media is always involved. Welcome to October. You'll start seeing pink paper towels, and maybe next week the Jaguars are going to wear pink shoelaces. This is October as we live it, right? So some of the things that we're looking at from an individualized screening standpoint is most women get mammograms. That is the only way that we've found to actually reduce the risk of death from breast cancer. Only mammography that's the only screening modality that does that. But what we've done as part of this STRIVE trial that we're participating in is tried to figure out, can we detect it earlier by perhaps a blood test that might detect circulating tumor cells? Maybe that can augment the screening mammogram that we're already doing. So this is really exciting. Mayo Clinic Florida has agreed to enroll about 5,000 women. I think Rochester is enrolling 10,000 women, and Arizona is enrolling about 5,000, just like we are. So actively looking at before women ever get breast cancer. There are a lot of different risk factors related to breast cancer, the most common ones being the fact that women are women and their age. So as we get older, that risk of breast cancer goes up. And then there's a whole series of things, some of which we can control, some of which we can't control, but all of which influence a woman's risk of breast cancer. So how do you actually synthesize this, and how do you come up with something that is meaningful? And that's really the question that we deal with every single day in the breast clinic. So I tried to make a list here of 5 things that everyone would like to know what they can do to maybe prevent their risk of breast cancer from the women in the room. And I think these are the things that come up recurringly. The first is maintain a healthy body weight, especially after menopause. So how do you figure out what a healthy body weight is? It's really based on what your BMI, the body mass index. So this is something you can Google online. You can put in BMI calculator. You can put in your height and your weight, either in metric or in pounds. And then it will give this ratio, and you really want that ratio to be less than 25. The second thing that we know is very good from a number of different levels is exercise. And the recommendation is at least 30 minutes a day, 5 days a week. The third is eat a colorful diet rich in non-starchy vegetables, fruit, whole grains, fatty fish, lean meats. So really I think the teaching is that Mediterranean diet. That's something that has gained a lot of traction. And when I talked to the nutritionist, she talks about cruciferous vegetables. I didn't know what those were and don't like, but the leafy greens, the Brussels sprouts, the kales, those kinds of things. can increase your risk of breast cancer. And really, this is postmenopausally taking estrogen and progesterone replacement to maybe not have some of those side effects that women have as they go through menopause. I'll tell you that this is a topic for discussion with just a more recent article published that might refute some of this data, but for right now, it's kind of a less is more approach. If you can get by without it, that's probably better. But the problem is what those hormones do is they keep your body in a premenopausal state where the breast tissue remains more dense. And when it's more dense, it's therefore harder to image on mammograms and then harder to see if there's something there. So it can mask. And then the last thing is understand your risk. So these personalized risk reduction strategies, they're actually medications that we can give to reduce breast cancer risk by up to 50 to 60% in the U.S. population. So what does that mean? So this, everyone knows who Angelina Jolie is, right? And she has an incredible media sensation, and if you followed her in the past, what you know is that she had both of her breasts removed. She has a BRCA mutation, which is one of the genetic risk factors where your risk of getting breast cancer in that situation is 50 to 80%. She was on People magazine 2 weeks in a row, and I mean, as I tell the operating room, you can't believe it if it's not in People, right? You can't go through the grocery store line and believe Us Weekly and whatever. It's not true until it's on People. She was also on the cover of Time, and this got dubbed as the Angelina effect. So what she did was she wrote an op-ed piece in the New York Times about her choice to have bilateral mastectomies. And yet it's really interesting when you dig into what she said and why she wrote it, because the fact is one of the things that she points out is that only 5% of women actually have a genetic 5% of women with breast cancer actually have a genetic mutation that caused it. And in her case, the risk of anyone without a family history having a breast cancer gene like this is probably 1 in 500 to 1 in 800. So it's not really that common. So there was this big deal about should everyone who's at risk go out and have both of their breasts removed? And in reality, when they've studied it, it's very interesting because where do you think most people got their information? How many people do you think actually read her op-ed? 3%. So 3% of people actually read her op-ed. Everyone else got it off Entertainment Tonight and People Magazine and everything else, right? So if you actually read her op-ed, she doesn't say, I had BRCA, go and get both of your breasts removed. What she says is, be empowered, know your risk, figure out what your options are, and if you need to, get genetic testing and then figure out what the right decision is for you. So it's very fitting, but the way it got distorted in the media is very different. So the other thing is, if we kind of leave that arena for a little bit, is there are post-treatment side effects. In the past, we were so focused on the treatment. Can we cure the disease that we kind of did it at all costs? And now the question is, well, can we figure out what the right treatment is that perhaps might minimize side effects for you? Because there's about 4 million breast cancer survivors that are living in the United States right now. So can we give you the treatment that's going to save your life, but perhaps the one that's going to influence your quality of life the least? What ends up happening is these women are faced with a whole ton of decisions, and it really is information overload. You come in and trying to digest and synthesize all of this information tends to be quite a challenge. I actually tell my patients that that's really my job. I'm a surgeon by trade, and my boss will tell you that my job is in the operating room, and he wants to know how many surgeries I'm doing. But in reality, my job is in the clinic, trying to sift through all this information and the data we have and trying to help my patients make the best decision for them. And although there's only 2 surgical options, there's 100 reasons why women choose whatever surgery it is that they choose. So to try to help patients navigate that, what we've done is developed this iPad app, which I liken it a little bit to choose your own adventure, if you will. You come in and it gets populated with your personal data related to your tumor, and then you take that iPad home with you, and then you can say, okay, well, if I do this, then what happens? And well, maybe I want to do this instead, and then these are the treatment side effects, and these are what the downstream, and this is what the surgical recovery is, and then this is what I can expect. So of course, you can guess what administration's concern was. Well, we're going to have all these iPads, and we're actually giving them to the patient. Are these going to come back? So we probably have about 60 iPads, and the patients keep them for at least a month, sometimes longer, and we haven't lost one yet, and it's been 2 years. So this is something that definitely has been very helpful for the patients. They can do it on their own time, and they can look at all the different scenarios to try to pick out what's right for them. And the last piece is really recognizing that cancer treatment in general is not about treating just the right breast or just the left colon or anything like that. It's really about the whole person and how all of that interacts together. And we have started to recognize the value of these integrative medicine type therapies. And so if we look at this I kind of abbreviated the integrative medicine definition, but in essence what it says is that is the practice of medicine that is informed by evidence and appropriate therapeutic approaches by all healthcare professionals and disciplines to achieve optimal healing and health. And so who wouldn't want that? Who doesn't agree that that's a good thing? What we found is that about 80% of cancer patients use integrative therapies, and a large bulk of these patients are in fact breast cancer patients. And they use these not just for prevention purposes, but also to manage many of the treatment side effects that we put them through. So these are the different integrative medicine therapy options that we offer here. This has really grown tremendously. It's headed by my colleague Dawn Musalem, who's very involved with many of these different opportunities. And really the one that we see patients utilizing the most is the acupuncture. But they do have cooking classes and nutritional therapy and yoga and all these kinds of things. When we look at the research actually behind the acupuncture, it supports any number of different realms and treatment side effects that we see in breast cancer. And overall, when we've studied it and done some pilot data, the quality of life in these patients who accept and use these integrative therapies is significantly improved in all domains. In all domains. So that's pretty impressive. That's pretty powerful data. So with that, I'd like to just show you some of the pictures of our beautiful space. If you haven't been up there, I'm sure Elaine or Sarah would be happy to take you, or I'd be happy to take you at some point. But it really is a wonderful place. We moved up here about 18 months ago, and breast imaging, so mammography and ultrasound, and then breast surgery, breast medicine, breast oncology, we all live in the same space, and that has, the best part about this space is you see that it's bright, it's open, and patients, it actually has a very calming effect when you're there, and just it has this atmosphere of hope. So it's really a wonderful place, and we're very lucky. Most other clinicians who walk through all of a sudden all want to be breast health providers. It's amazing how that works. And so that's it. So I'd be happy to take any questions and anything else, Sarah. No? Yeah. Okay, so do you still need participants in the study? So we have lots of studies going on. Probably the biggest study that we have, the STRIVE study that I talked about, is really important. The other study that we have, which is really more of a registry, and the registry is prospectively collecting both quality of life data, but tissue data, tissue samples from women who have breast cancer or having surgery. We're saving that tissue, and we also then save blood that matches with that, and then that gets distilled down into DNA, and that's available for our researchers to use. So that's ongoing. We definitely have the probiotic study is open. The vaccine trial is now open, or almost open today or tomorrow. So there's all kinds of things. My goal is that everyone who comes into the breast center should be eligible for some kind of study or trial, and we're working towards that. The other question is, should I keep taking low-dose Premarin? So the previous data suggested that that combination hormone therapy was actually the one that puts you at the highest risk for breast cancer. When we look at the numbers, it was an increase in risk of about 30%. What that means is that if the general population risk is 10 to 13%, it's 30% of that risk. This is the point. I mean, it's statistics understanding those numbers. So it probably higher end of the normal risk. Other family at risk otherwise. Okay, so my 45-year-old daughter's grandmother had breast cancer. Should my daughter have genetic testing to see if she is at risk? So really good question. The indications for genetic testing have really been broadened significantly, and we're learning so much more about that. I didn't get into this, but at the time that Angelina Jolie comes out and says, hey, get tested, at the same time, the genetic testing world kind of totally exploded with everything that they had going on, and where we used to only test for 2 things, now they can test for 25 or 30 things. And so there's been a lot of testing and retesting. The bottom line, though, is the best person to get tested, regardless of the cancer, is the person with the cancer. That's the best person. Other people can get tested, but sometimes those results can be what we call an uninformed negative. So in other words, if you get tested and you have the cancer and you have the gene, then there's a chance that your child or your sister or your sibling or whoever could have that gene, and they're going to test you for that specific gene. If, however, you get tested, or if, however, the person with the cancer didn't get tested, and so in this case, the daughter gets tested, and the daughter doesn't have the gene, you don't know if the mom had the gene or the grandmother had the gene or didn't have the gene. I don't know, did I explain? Does that make sense? Okay, so the point is that testing someone without cancer can be uninformative because you don't know what the rest of the family is. If the rest of the family has the gene and that person doesn't, then that person's at general population risk, not at the elevated risk of someone who has the mutation. Now, the problem is that we see families all the time where multiple generations and multiple people in each generation have cancer and they've been tested and don't have the gene. So what does that mean? That means that they are still at elevated risk, that there probably is a hereditary or genetic component to their cancer. We just don't know what it is. We can't identify it. So, let's see it. So immunotherapy now available to all triple-negative breast cancer patients. So not necessarily. It's patients who have previously been treated either with neoadjuvant chemotherapy or have gotten chemotherapy for their triple-negative breast cancer within the past year. Those patients then are getting vaccines or can get vaccines as part of the trial to then study their immune response and hopefully reduce the risk of that triple-negative cancer from coming back. So I think this is a patient who, or someone who's previously had endometrial cancer, wondering if that influences breast cancer risk. It sounds like they were treated with surgery and chemotherapy. So that also a good question. The fact is that there's no link between breast and ovarian or endometrial cancer unless you have that BRCA mutation. So again, if we go back to the Angelina Jolie thing, she got a lot of press on having her breasts removed. But really the most important thing in those patients who have that BRCA mutation, what saves their life is not removing their breasts, it's actually having their ovaries removed. So it was only 3 years later that she came out and said, I had my ovaries removed. You know, that may have been a year or two, 18 months ago, something like that. But that was kind of my problem with the data. She got all this press about removing her breasts, but in reality what was going to save her life was the ovaries, and that was there was very little publicity about that. So in general, no risk between breast or ovarian cancer unless you have that BRCA mutation. I'll stick around for a few minutes in the back if anyone has other questions they don't want to ask in person. Okay with that.
One thing I failed to mention as we started this morning is that not only do we have participants in this room, but we have participants who are joining us via Mayo Connect through an online viewing of this event. So we welcome those participants as well. I think I didn't mention them because I was a little nervous thinking there are people who are viewing this whom I can't see. So, but we hope that they're there and enjoying the presentations as we are this morning. We're certainly thankful for Dr. McLaughlin's presentation. One of the things she talked about, integrative medicine and breast cancer patients, we'll be talking about again on the 11th of October at our Women's Health event. And if you have not registered for that, you may want to come and hear Dr. Musalem, who will be one of our presenters. Our second presentation this morning is from Dr. Neil Graff Radford. He will share research and the latest insights from Mayo Clinic's Alzheimer's Disease Research Center. Dr. Graff Radford is a neurologist, and he's the medical director of the Mayo Clinic Memory Disorders Clinic. He's also the associate medical director for the Department of Development here in Florida. He's a terrific partner in all of our efforts. Like Dr. McLaughlin, he urges people to get adequate exercise, and he may talk about that today. In fact, it's been influential on me. Whenever I exercise, I think of Dr. Graff Radford and his encouragement. And so we thank you very much, Dr. Graff Radford, for joining us.
Thank you very much, Elaine, and thank you all for attending. My talk is obviously geared towards preventing breast cancer because I'm going to give the same suggestions as Sarah gave for diet. You'll see in a minute. It's quite interesting that those things are healthy. Anyhow, there are 3 stages of life, you know. There's childhood, middle age, and looking good. And I'm going to be talking about that area. So these are my disclosures, and the map of my talk is going to be first on history. This is Alzheimer's first patient. Her name is Auguste Dieter. She was diagnosed in 2007, in 1907 by Alzheimer, and she was, how old? What do you think? Looking at her, 52. Maybe Alzheimer's causes the rest of you to age. Anyhow, this is Alzheimer's notes. He said, "What is your name?" And she said, "Auguste." Last name, Auguste. "What is your husband's name?" "Auguste, I think." "How long have you been here?" She seemed to be trying to remember. He wrote in his notes, 3 weeks. It was 2 days. And she poignantly said, "I lost myself." That's what's so sad about Alzheimer's, is that those memories and all of that seems to go by the way. So tragic, and we really need to prevent it. One of the interesting things, though, is that this is 2 studies from England showing that the prevalence, how many people out there have dementia, not just Alzheimer's, but dementia, has gone down. That's amazing. We always thought it was going up, but it's actually gone down. And maybe that's because we're treating blood pressure and cholesterol and those other things much better. We've verified this in Mayo Clinic Rochester in the Olmsted County study, and they also validated it in Michigan. So this is becoming quite well known. We need more of this, and that's what I'm going to be talking to you a little bit about, is that prevention is really, really very important. So what are the risk factors? Getting older is one of them. At the average age in 1907, people lived about 42 years. Now the average age people live, certainly in Japan, over 80. In the US, high 70s, or if you're a woman, over, low 80s. People are living into the risk period. That's the most important risk of it. Also, family history. About 60 to 80% of Alzheimer's is genetic. That's quite amazing. But don't despair. You know your cholesterol level is genetic, as your blood pressure level is genetic, but we have treatment for that. We're going to have treatment for this too. The known mutations that cause the disease, that are passed generation by generation, are very rare, less than 2%, very rare. So it isn't what you inherit really is a risk. You don't inherit usually generation by generation. If my mom or dad had it, I have a 50% chance. That's a rare group. However, this gene called the apolipoprotein E4, now that's on the quiz, isn't it, Elaine? Everybody has to remember that. No. The apolipoprotein E4 gene, which is common, actually gives about 20% of the risk of Alzheimer's disease. About 13% of the Caucasian 13 to 20% of the Caucasian population carry the one of the ApoE4. 2 out of 100 carry 2 E4s. Those people have a 12 times greater chance of getting dementia. It is a risk factor. People with Down syndrome almost invariably get dementia. Being a woman is, one of the reasons women have a greater chance of getting dementia is they live longer than men. They're more in the risk period. But we think there's other factors. For example, hormonal factors may be important. Head injury is a very important cause of dementia. Its association with Alzheimer's disease is, a question. But this traumatic brain injury you're reading about with football players getting this traumatic brain injury, that's a real phenomenon, and it's different to Alzheimer's. And then factors associated with atherosclerosis are really important risk factor, definitely in dementia and probably in Alzheimer's. So I'm going to tell you the NUN study. This is a very important study. Somebody culled my slides, and I don't have the other slide to tell you about it. So let me put this on B and tell you about the NUN study. So the nuns very graciously decided to join a study to donate their brains and take part in trying to understand Alzheimer's. And what the nuns did before they took their vows at age 23, wrote an essay in their own hands saying why they wanted to take their vows. And a very, very clever linguist took those essays and analyzed them for density of ideal complexity as a sort of a mark of how smart these nuns were at age 23. And the idea was that if you were a smart nun at 23, you would get Alzheimer's disease, but it wouldn't show because you had reserve. But actually, what happened was the nuns that were smart, that had high density of ideas, had less pathology in their brain. So if you're a smart nun at 23, you had less pathology when you died at age 80. So what does that mean? Does it mean that the genes that make you smart also prevent Alzheimer's disease? Does it mean if you're a smart nun, you're going to be a teacher, so you're going to keep your mind busy, and if you're not such a smart nun, you're going to work in the same colony, but you're going to prepare food and not do much intellectual activity? Very interesting hypotheses. We don't know the answer to that, but it raises this very important factor that keeping your mind busy may be an important thing. So this was also looked at in what I would call a bad study. This study is a study which has circular reasoning. And what Dr. Katzman did was he gave a questionnaire to people in the Einstein study of aging and asked, what are your activities? and they would say, I play bridge, do music, I do crosswords, I do square dancing. All of these activities were put together. And then those who did a lot of activities had less chance, played frequently, had less chance of developing dementia 15 years later. But what I'm going to tell you just now is that Alzheimer pathology begins 15 to 20 years before the symptoms. So maybe they weren't playing so much because the Alzheimer's had already started. So this kind of study is called circular reasoning. And so you have to be very careful about epidemiology studies. So this is one of them. Now, physical activity also is very important. Here's one study, the Nurses' Health Study, which has 18,700 people, and those who exercise in the questionnaire had less chance of getting cognitive decline when they tested them on the phone. And that's a problem. This particular study, because again, it might be circular reasoning because they might have not been exercising because the dementia had already started. So it's interesting, but not proof. Here's a study on hypertension and cholesterol. This is from the United Kingdom, and that people with high blood pressure, systolic blood pressure of 160, and a high cholesterol, 6.5 millimoles, I'll translate, that's 200, a cholesterol of 200, had a 3.5 times greater chance of getting dementia later on. So that is really important factor. And however, if you treat hypertension with any of the blood pressures, ACE inhibitors, ACE receptor blockers, calcium blockers, beta blockers, many of these, you have less chance of getting dementia as well. Those are all significant. So treating your blood pressure is a really important factor. And here's a very amazing study from Medicare. Look how many thousands of people, 160,000 in that group. These are people who were prescribed statins. And some of them used it, and some of them didn't use it. So they all had high cholesterol, but they knew who filled their prescriptions. And the ones who used it and didn't fulfill their prescriptions, the ones who used it had less chance of getting Alzheimer's disease. So people who used statins were protected against getting dementia. So I know there's folklore on the internet that statins cause memory problems, but actually overall, it may be one of the reasons that the prevalence of dementia is actually going down. You can see that, so that's really very interesting. What about vitamin D? Vitamin D, I'm going to call the Goldilocks vitamin. Too much, no good. Increase calcium in your heart. Too little, memory problems. Just right, Goldilocks. It's got to be perfect. So vitamin D, now we're lucky we live in the sun a lot, but in Rochester, people have low vitamin Ds in winter. And so I would recommend that you have your doctor measure your vitamin D. If it's low, take it. If it's not low, don't take the supplement. What about exercise? The most important study in exercise is this study. This is a randomized prospective study. Let me tell you a little bit about it. So Dr. Erickson and his colleagues took people who were average age 67, and half of those people for a year did toning, stretching, and balancing. That's very good for you because you don't fall and break your hip if you're good at that. The other group did aerobics. They did that 150 minutes that Sarah was talking about, the 30 minutes a day, 150 minutes of aerobics. What is aerobics? It's getting your pulse to 100 and a little bit above so that your heart's going a little bit faster. Walking 4 miles an hour on the treadmill, probably enough, for 150 minutes a week. And then they followed those people, and what did they find? I think they mixed up my slides here, or took out one. But what they found was that the hippocampus is the brain, part of the brain that makes memory. And the hippocampus got bigger in the ones who did their aerobics. So it increased the size of your brain. It made new cells in the brain. That's quite amazing. And the bigger your hippocampus, the better your memory. And the bigger your hippocampus, the higher and the fitter you were, the higher a growth factor called brain-derived neurotrophic factor went up. So exercise increases a neurotrophic factor, makes the brain, the hippocampus bigger, and makes your memory better. Here's a randomized prospective study, level 1 evidence, that exercise is really good for your brain. Whether it prevents Alzheimer's disease is not known, but certainly it's very healthy for your brain, and you just heard it's good to prevent breast cancer too. Now, alcohol use, 1 or 2 drinks a day is supposed to be protective, and this is the Women's Health Study. Recently, there's been a controversial other study saying maybe not so. So I think the jury's out on the alcohol, but when I tell you about the Mediterranean diet, which involves a glass of wine a day, I think that's absolutely compelling. So we're going to talk about some of the other spices. Polyunsaturated fats, what are those? Those are the oils that you have, you know, not olive oil, but safflower oil or other oils that you use to cook are protective. And olive oil is really good. And eating fish is really protective. And curry spices are protective. And antioxidants, you saw Sarah tell you about eating colored vegetables. The reason she's telling you that is they have antioxidants in. That's what colored vegetables do, including green color. So all those colored vegetables have antioxidants, and those are protective. So here's a study on antioxidants in elderly beagles. So these elderly beagles were given alpha-tocopherol, carnitine, all antioxidants, and guess what? Elderly beagles started learning new tricks. So it was actually helpful in the dogs. But the Mediterranean diet is actually very protective of the brain. And what is the Mediterranean diet? Here it is. It's vegetables and legumes and fruits and cereals and high intake of the unsaturated fats. That's not the butter, not the cream, not the red meat. Mostly in the form of olive oil, low intake of saturated fats, moderate high intake of fish 3 times a week, a low moderate intake of dairy products, and low intake of meat and poultry. So that's what you guys need to do. This is the MIND diet, so it's combining the Mediterranean diet and the diet for blood pressure. It's called the MIND diet. And you can see very much the same thing. Leafy vegetables, berries, nuts, oils. Don't eat butter. Don't eat cheese. Whole grains. Eat fish, beans, poultry, not much. Red meat, not much. Fast fried fat foods, don't eat those. Pastries, don't eat those. Wine, do drink that. So that's your MIND diet. Sleep apnea. One of the best things you can do for your partner is tell their doctor if your partner snores. Particularly if they go, and stop breathing in the middle of the night. That's apnea. That shrinks the hippocampus. But the good news is, if you treat the apnea successfully, the hippocampus gets big again. So something you can do about it. So that's really important. And dental disease causes inflammation and accelerates atherosclerosis. And some of the studies, one of them called the proton pump inhibitors, which are used for reflux, many of you might be taking these, have been associated with memory problems. And then also anticholinergics, those are drugs that they use for the bladder. If you have urgency, they may be giving you those kind of medicines. Also the over-the-counter sleeping medicines, Tylenol PM, NyQuil PM, all of those, they're bad for your memory. But they may even, if you take it long enough, have a permanent effect. That's what's worrisome. We always thought it would just go away, just stop it. I stop it all the time in my patients, but I worry how long they've been doing it. So here's our recommendations then. So treat cardiovascular risk factors, keep your mind active, exercise, a B-complex vitamin, vitamin C, vitamin E in food. Don't take vitamin E supplements. That's actually dangerous for your heart. Eat fish at least 3 times a week. Antioxidants, use curry, but don't take it as a powder. Use it to cook because it's not absorbed as a powder. The Mediterranean diet, quality sleep, increased socialization, I didn't show you that, dental hygiene, and avoid those 2 medicines. So that's what you can do right now in prevention. Now, to show you what we're doing in treatments, I need to educate you a little bit on how Alzheimer's works. The first thing that happens is that amyloid is deposited in the brain. And you can see this now on a PET scan of the brain. And that occurs about 15 to 20 years before people get symptoms. A few years later, we can see on a PET scan that the brain's not working, metabolizing glucose well. Then the next thing that happens, we can see the brain's getting damaged because tau protein is released into the spinal fluid, and we can see it on a PET scan that tau has been deposited. Only then can we see the brain shrink, and only then can we diagnose mild cognitive impairment, and then later we can diagnose dementia when it is quite severe. So that's the sequence of events. So now that you know that, you can see that when the amyloid is deposited in the brain, it takes 15 years in the Australian ABLE study before you get dementia. That's like a 15-year window to prevent the disease. We call it secondary prevention. It's like you're beginning to get hardening of the arteries. We know it's beginning. You're depositing amyloid in the brain. We know it's beginning. Now let's intervene. Let's take our Lipitor and Zocor and blood pressure and exercise and prevent the heart disease. Let's remove that amyloid from the brain. Let's do other things that we can do to prevent it. I'm going to talk to you then how that we can really do that now. So there have been a number of clinical trials that have failed hopelessly when people have Alzheimer's disease. Here's one of the latest ones. There are about 35 phase 3 studies that didn't work, and some of them are anti-amyloid drugs. But here's one of the newest drugs, with this drug called aducanumab, and you can see this is the amyloid PET scan that with placebo doesn't move. If you give 3 milligrams, it removes it. 6 milligrams, it removes it. 10 milligrams, it removes it even more. So we can intravenously give an antibody in the vein every 4 weeks and remove that amyloid from the brain. Here's evidence. This is published in Nature in 2016, not that long ago. And we're involved in this study now to to slow down the disease at the stage where people have that mild cognitive impairment. It also improves things like the memory. This is the CDR sum of boxes. So not only is it removing amyloid, but in the mild cognitive impairment, in the first 180 patients, this is only a phase 1b study, it actually worked. Their memories improved. So it removes the amyloid and their memories improve. This is a Biogen study that we're involved in. So just to give you an idea of the studies that we are involved in now, we're involved in the Biogen study, we're involved in a Lewy body study, we're involved in an insulin sniffing study, which is an interesting way. It's completely safe, and there's evidence in a phase 2 study showing that it worked. We're involved in a prevention study called the A4 study, where we're injecting an antibody in that window of secondary prevention. And these people are being followed for 5 years. We have finished entering 1,140 patients, not here only. We're just one of the centers. And now we're following them for this 5 years, infusing these antibodies every 4 weeks to see if we can prevent the dementia. It's really quite stunning. There's a study called the IDEA study. That PET study is not paid for by Medicare. And if you have it done privately, it's $7,000. So we have a study now where we can actually do that in people who we're not sure what the diagnosis is. Is it frontal dementia or Alzheimer's disease? And Medicare will pay for this studies to see if it is worth doing. And there's a study called the A5 study, which is another prevention study. So instead of coming every 4 weeks and having an infusion, we can give you a tablet that prevents that amyloid being made. That's quite amazing. So that'll be a tablet study, and it's going to be, again, a 5-year study. We have another study where we can treat Alzheimer's disease with that tablet. And then there's a study, remember I told you about that ApoE4 gene? People who have 2 of those genes, 2 out of 100 of the population, who had great risk of it. We have 2 studies, two parts to the study. One is we are immunizing them. They're making their own antibodies against the amyloid. And also we're giving beta blockers to make it. Now, amyloid's not the only protein that's associated with Alzheimer's. There's one called tau. And now we have an antibody that we're giving to Alzheimer patients against the tau protein. That's by a drug company called AbbVie, which used to be called Abbott Laboratories. You and I will remember it, but it's now called AbbVie. So those are some of the studies that we're doing at Mayo Jacksonville right now. So in summary, the dream of all of us is to delay or prevent the disease. I think we have hope that that might happen now. I think a combination of the genetics and biomarkers, we are able to identify those at risk, and then secondary prevention is now underway at Mayo and in other places around the country, and we should have the answer to that. We are also treating mild Alzheimer's disease, like that Biogen study as well, but that's got to be in the mild phase. So I'll stop there and entertain any questions if you have any. So this one was, please comment on statins contributing to dementia. So I did show you that one slide where I think, and there's several other studies on that statins are protective of the brain overall. So why in the world is there this stuff in the internet, not much in the literature, that statins cause memory problems? And the reason is that the University of San Diego, a group, put out a website saying, if you have statins that cause memory problems, contact us. And so they were contacted, and then they studied the group that said that they had memory problems from statins. And how did they study them? They asked them to stop their statins and see if their memory got better, and then start the statins again and see if their memory got worse. That's not a good way to study this project. So you've got people who already think it is, and now you're going to ask them to stop and start it without telling them whether they're stopping or starting it. And it's a self-fulfilling prophecy that it's going to happen. It is entirely possible that statins may have an idiosyncratic effect on a few people to cause memory problems. But I would not stop statins from a memory problem unless it had been proved in that particular person. So that is what I would say. The other question was, are there any alternatives to statins than if you have problems? Well, there are other problems from statins that we have to stop, particularly muscle problems. People get abnormal and muscle weakness and high abnormal enzymes. There are a few people who do that. And so there are some dietary factors that might work for that. And now there's injections, immunizations against certain drugs, but they cost like $130,000 a year. Depends how bad your problem is, whether you should use that particular medication. Niacin, slow niacin lowers cholesterol. That's another thing that you can take over the counter. There are other medicines, but they don't have the evidence that lowering your cholesterol actually is as helpful. Statins, when they lower the cholesterol, may not be the cholesterol, may be other factors, like it's also anti-inflammatory, and it is protective against cardiovascular disease. All right. The next one is, what are the criteria used to be admitted to a study? So it depends. The best is to call us, and we'll see where you fit. If you are cognitively normal, we've got a study, a prevention study for you to screen for. We would test that you're cognitively normal. You have to have a PET scan, which the study pays for, and you have to have the amyloid in the brain. Otherwise, you don't qualify to get one of those anti-amyloid drugs. So that's in the cognitively normal. If you have a mild cognitive impairment, so that's a mini mental score of 26 and above, so just a mild isolated memory problem and an amyloid PET study, then you would maybe qualify for that aducanumab study. So depends on where you are. The best is to call my office at Mayo and ask to speak to one of my coordinators, and they could tell you where you might fit. The next one is so should I have genetic testing because because one of the parents had a dementia. So you should not have genetic testing from a clinical point of view unless you want to take part in a study. Then it's worthwhile. So if you found out that you had carried ApoE4, you would just worry about it. And it wouldn't really make much difference. You can do those lifestyle things that I've told you, which everybody should do anyhow. That's what you can do for prevention. However, say you wanted to take part in the ApoE4 study, then the way to do that is to go online and look up a thing called Gene Match, Gene Match, and contact them, and they'll send you a kit, and you'll swab your cheek and send that in, and then they won't tell you your gene type, but they will tell you if you qualify for a study and which place is near you that part in a study. That's for the ApoE4. So that's called the Gene Match study. That's the only time I think it would be worthwhile doing any genetic testing. Will PET scans be able to identify tau or earlier signs of Alzheimer's disease? Will that be done on routine? So a PET scan, the first change in Alzheimer's is the amyloid. We do have PET scans, and we are doing them at Mayo, Jacksonville, and Rochester for tau. So there is a PET scan for tau, and it's really helpful in many ways in understanding. But first things is the amyloid. The question was, are we going to do this in our routine annual physical? You're going to have a PET scan to see if you're at risk of Alzheimer's. I think that's going to happen. When we have prevention, we have good prevention for colon cancer, right? And we're all willing to undergo colonoscopies, or most of us. I think we'll be willing, if there's a prevention, say the A4 or the A5 study works. We'll want to know if we have amyloid, because then we can start the prevention and prevent Alzheimer's disease. So I think that's coming. So the answer to that is maybe soon. How do you determine who to treat? So I think the question could be expanded. How do you determine who to treat, and at what stage should you be treating? So at the stage of Alzheimer's disease, we treat everybody, and it's not just giving them medicines like Aricept or Namenda to improve symptoms, because that doesn't prevent progression. But we do prevent, we give them a whole list of things that are good to slow it down. For example, it's known that if you treat the vascular risk factors at the stage of dementia, it actually slows it down. If a drug company had that, they'd be making, if it was a pill that slowed it down as much as treating blood pressure and cholesterol, that actually slows down dementia. There's a study from France showing that that's the case. So we treat that, but we also treat the whole family. When a person gets dementia, the whole family is affected. And so we do counseling of the family. We talk about caregiver support. We talk about tips to improve memory. We talk about prognosis. We talk about lifestyle changes. We talk about living wills and things like that that are really important. We talk about the risk of driving. So the whole family needs to be involved with that. So we treat everybody at that stage. So I think those are the questions I have. Is that time?
One more. One more.
Thank you. Do we still want individuals to donate their brains after death for research? And the answer to that is yes. So we have one of the most successful brain bank donation programs in the world at Mayo Clinic in Jacksonville. I think Dr. Dixon, who's our neuropathologist, has more than 3,000 brains collected and characterized. And we've used all of those brains in all the genetic studies. So when you definitely have an absolute diagnosis, the genetics is crucial at that stage. So all of those people's DNA have been included in the massive studies. So they've discovered the 24 genes that are at risk, that are the risk genes for Alzheimer's disease, with all of those brains. So together we've combined together, there's 64,000 people in that study, and Mayo Jacksonville contributed 3,000 of those specimens from the brain bank, and from our blood collection another 3,000. So we've made a major contribution to the whole discovery of all of those genes. So, and we've also used those brains to discover Lewy body patients and frontotemporal dementia patients. All of this is absolutely crucial. So the answer is yes, very much so. So thank you so much for your attention and attending today. Really appreciate it.
Thank you, Dr. Graf Radford, and thank you for those good questions. We're going to have one more presentation before our break. If you are getting hungry, there's still some snacks over there. Unfortunately, I don't think we have any curry. And really, unfortunately, we don't have any wine either. But we will go ahead. Our final presentation before lunch is by Dr. Alex Parker. And we're glad to have him here as another Associate Medical Director along with Dr. Graf Radford. He is the Carmichael Family Director of the Center for Individualized Medicine. That's right. And he's also Vice Chair of Health Sciences Research, and we have heard from him in a variety of presentations. You've probably heard Dr. Parker talk before about genetics, pharmacogenomics, or about the Center for Individualized Medicine. Today he's going to come with a different topic, which is strategic priorities from our campaign, You Are the Campaign for Mayo Clinic. Thanks, Dr. Parker. You're standing between us and lunch.
Wholly appropriate for how I was going to start this off. I was going to start this off talking about a lot of challenges. That's what's going to be kind of the theme for my little bit here. Challenges. I've had a lot of challenges. I mean, work-related. I've had some grant deadlines. I've had 3 or 4 talks this week. You know, all kinds of stuff sort of happening there. I've had, you know, personal challenges. I have a daughter that's a freshman in college now, and everything that comes with that. I have a 7-year-old that can't get her shoes on the right feet, and I keep getting notices from the teacher that, you know, Avery's shoes are on the wrong feet again. And then I have parents who are asking about moving to, or maybe threatening to move to Jacksonville is probably the better way of putting it. So a lot of challenges. If you let me, since we got a little extra time, I might even go a little deeper, show you how challenging my personal life is right now. I told you I have a daughter in college. Well, she's at Florida State, and my dad went to Wake Forest. And this past weekend, they played each other. And, you know, Saturdays I like to relax and just watch football. So this Saturday, I didn't even know what shirt to put on because my daughter was saying, "Are you pulling for the Seminoles?" And my dad said, "Clearly you're pulling for Wake Forest." Meanwhile, I'm wearing my Carolina shirt. So a lot of challenges. But today, and thank you, Elaine, for adding to my challenge, I got a tough job. In 10 minutes, they wanted me to cover all the strategic priorities for Mayo Clinic. And then they said, and we want you to do that sandwiched between some real rock stars. So we had Sarah McLaughlin, who's just amazing and awesome and you know, a leader in her field. And then Neil, who, in addition to being really smart, I think his voice is like velvet. I could just listen to it all day. So you're going to follow those two, and then you're going to be right before lunch, and then after you will be Dr. Q. So I'm like, okay, so I got 10 minutes to do this, and I'm sandwiched between these rock stars, and it's before lunch. So the challenges continue. But I'm up to the challenge. So what I'm going to try to do, let's manage expectations. I'm going to cover some of the strategic priorities that Mayo Clinic has set out to keep the needs of our patients at the center of what we do. That's what we're focusing on, but also to make sure that we continue our success as a leader in healthcare. Don't try to read them all, because we're going to go through them one by one. And we're going to start with my personal favorite, the center that I lead, the Center for Individualized Medicine. And obviously, I'm not trying to give you a deep dive in here. This is just sort of hit the highlights, and then if you have questions, I'll hang out for lunch and we can talk more. But this is our center where we are tailoring the healthcare to the needs of each patient using their own genetic code. You know, everything from what Sarah talked about, genetic testing for risk of breast cancer, all the way out to something like doing genetic testing to figure out what's the best treatment for someone with irritable bowel disease. So again, we're using your own genome to guide your healthcare, and that's because we want to optimize healthcare. We want to make sure we're driving out inefficiencies, but really at the heart of it, what we want is care that's more individualized, and using your own genetic code is the best way to individualize your care. Couple very quick examples. One of the ways we're doing that, and it's not research, it's practice. This is happening in our clinic today. We're using it to end the diagnostic odyssey for patients with rare undiagnosed diseases like Dustin Bennett, sequencing genomes and finding answers for patients. Again, that's the periphery of medicine. We're also pushing it deeper into the practice, using genetic information to get the right drug to the right patient at the right, or the first time, the very first time, and drive out those inefficiencies and get the medication to the patient they need. This is this subfield of individualized medicine called pharmacogenomics, and we're referring to it as genomics for everyone because we're all either on medications or we're going to be. So again, just a high-level overview of that being one of the strategic initiatives. Another is something called the Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery. This is a group, I'm going to read what it says there, and then I'm going to tell you what it actually is. It uses data-driven science to improve quality, safety, and value of healthcare. Put simply, that's realizing that our practice is actually like a lab. We can test things. We can say, well, why do we do this when this might be better? Let's try this, compare it to this, see which is better, and then move forward. So this center treats our practice like a lab where we can test all kinds of different things, from which contrast should we give before a CT scan, the one that's more expensive or the one that's a little cheaper, and see which one's better, which one gets better outcomes, and then use the right one. So we're treating the practice like a science and doing it in a way that really keeps the patient at the focus of what we're doing. Just this morning, this group gave an update to our board about a very simple study they did that showed that they could free up 20 minutes of dictation time for the physicians by essentially implementing a new process. They implemented it in one area, didn't implement it in another. These physicians had on average 20 more minutes to do dictation. So now we say that's great. That gives our physicians more time to spend with patients. So again, it's just treating healthcare like a lab that we can test things, and then we find the answers, educate ourselves, educate our colleagues, and then educate the world. Third area of focus, again, strategic focus, is the Center for Regenerative Medicine. This is just basically harnessing our body's natural ability to heal itself. This is the stem cell stuff. And if you're following this field, it's really advanced away from a lot of the politically charged issues of where the stem cells come from, to now we can take a skin cell, deprogram it back to its basically baby state, if you will, and then reprogram it to become whatever type of tissue we want, whether it's a heart cell, a brain cell, a liver cell, whatever we need. So this is what I like to refer to, and if the RegMed people ever hear of this, I'll deny it. This is actually the really cool center that's at the forefront of medicine. I would deny that I said that. It's the individualized medicine. They're at the forefront because this is really, really cutting-edge stuff. Now that comes with good and bad. And by that I mean there's a lot of places that are taking this concept, this technology, and offering services that, let's just say, there's not a lot of evidence behind it. There are places that are saying, come here for your knee replacement, we'll inject some stem cells and you'll have a great outcome. There's no evidence behind that right now. So my point about our Center for Regenerative Medicine is we've actually built regenerative medicine suites in our practice. These exist, and we have the region's only regenerative medicine therapy suites. But the point here is this is where the real evidence-driven stem cell type therapies are happening. You have to be very careful about what you're hearing about other people doing. This is it's a little bit like the Wild West. And to me, it just underscores Mayo's importance as being a place where we vet the evidence, we decide what's ready for practice, and then when it's ready, we drive it into practice. Fourth area, the Center for Biomedical Discovery. So the other centers I just talked about are really about kind of taking what's out there and getting it into the practice and then testing it in the practice and seeing what works. Think about this group as being the ones that are really at the ground level finding the new discoveries. This is that critical starting point to solve our most pressing problems by understanding the essence of disease. I'm going to be very honest with you. somebody made these slides for me, so some of the words are tripping me up a little bit, but the essence of disease is what we're getting at here. So an example of what's coming out of this center, vaccines for breast and ovarian cancer. His team is working on a new vaccine. Again, they're studying the biology of this disease and developing a vaccine that will help your own immune system fight off cancer, both for prevention, so maybe you never even get diagnosed. Again, this is a vaccine we're talking about. But even for people who've had certain types of breast and ovarian cancer, providing them this vaccine to prevent their cancer from coming back. But the point is, in the Center for Biomedical Discovery, you have to have people working at sort of the foundation of disease to understand how it works. These are the people that do a lot of the hard work, and then we have these other centers that are looking to take this information and push it into the practice. This would be the fourth area of focus is the Mayo Clinic School of Medicine. Kind of using this mantra now, we are one school at 3 locations. The Mayo Medical School is officially open at all 3 locations. Some highlights of why this is a focus: we want to elevate the school's national profile. There's still a lot of people that don't know that Mayo Clinic actually has a medical school. But more importantly, we want to sustain a new model for for medical education. We have a lot of cutting-edge technologies and protocols and syllabuses for how medical education should be put out, and we want to be sure that we're kind of sustaining this through this new model through expanding the medical school. Couple fun facts about the class of 2017. They admitted 54 students to the Minnesota campus from nearly 5,000 applicants. 54 students out of 5,000. 50 students to its Arizona campus from 3,000 applications. And then we've just recently opened here in Florida with 8 students in the class of 2021 that will complete their final 2 years of study here on our campus. And out of those, there were 500 people that said they wanted to do that, and we're taking 8. So if you do the math real quick, that's less than a 2%. That means we're one of the ones that people want to come to. Less than a 2% chance, I'm sure Dr. Frugia would get in. He'd probably get into all 3. But, you know, a guy like me would have had no chance. But the point is, we're pushing the school, we're pushing out, but we're not, it's not at the detriment of the reputation of this being a school that people want to come to. And sorry, Dan, there's no plans for a football team. Although the way my Tar Heels are playing right now, I think if Mayo Med School had a football team, I think they'd probably give them a run for their money. Let's see, this is the fifth area, the Mayo model of care. This is the one that I really enjoy sort of spending some time talking about because, you know, we think about the Mayo model of care, and let's remind ourselves what it is. It's really about preserving the time for physicians to spend with patients. It's not rushed. And this isn't lost on even the next generation. My daughter's seeing dermatology here. And she said, you know, it was amazing, Dad. The dermatologist came in and talked to me, and then we covered everything. And then they took the time to say, well, do you have any other questions? You know, and she said, I really didn't have any, but it was nice to know that if I did, there was time to answer them. So that's obviously that kind of tenet of the Mayo model of care. The other is that we work in teams and we integrate and collaborate. It's that multidisciplinary approach. You know, if you come here to see oncology, but you need a cardiology consult, you don't have to leave and go somewhere else. You just go right down the hall. So preserving time and working in teams, that's that Mayo model of care. And healthcare is obviously changing a lot. So we just want to be sure that, you know, we're focusing our efforts and our resources on maintaining that care because we know that by doing that, we deliver that unparalleled patient experience and we get better outcomes. So the final one, and I'll use this to transition, is really just something we call the competitive market plan. And these are 4 areas that we have said we really need to focus on and put resources into research and practice to make sure that we stay at the top of our game. And they're not going to surprise you. It's cancer, it's transplant, neurosciences, and cardiovascular disease. But I want to use this to transition to what we'll call the tacit 7th area of focus, and that's the Florida Destination Medical Center Plan. What we mean by that, first of all, is we want to become, we've invested $330 million to become the destination medical center for the Southeast. That means we want people to leave the doorstep of Emory and get to Mayo Clinic when they need high acuity complex care. We want their first thought to be, I better get to the Mayo Clinic. We want people to leave the doorstep of Vanderbilt. We want people to leave the doorstep of Duke, which as a Carolina guy I think everyone should do. But we want people to be coming here when they say, for routine, if they feel like their local, provider can do that, that's great. But when they have something complex, whether it's, a hip replacement, a brain tumor, something where they say, I need the best, we want them to come to Mayo Clinic, Florida, and that be their first thought. So we've invested a lot of money in this. But we haven't done it willy-nilly. We actually have a formula for how that money will be used. One is we need people. So we were adding 100 physicians and 500 allied health staff, as Dr. Ferrugia likes to call it. We're investing in talent. And the talent that's already here and on its way, I interview a lot of these people, it's top-notch talent. So we're investing in talent. We're investing in space, 400,000 square feet of new space that will nearly double our space for patient care. Double our space for patient care. That's pretty impressive. And then the final one, people, space, we need technology. We're investing in the technology to keep us at the forefront. Things like the cyclotron and our molecular imaging suites, our 8 new operating rooms that will be state-of-the-art, our lung restoration center, and a little pitch in there for research. We're investing in a state-of-the-art biorepository that the NIH just recently chose to house the million-member, all of us patient cohort from the entire United States. So, we're investing in these things, and they're already paying off. So let's talk about space as I sort of wrap up here, because this is one that transitions into something that I'm sure you've noticed. Hard hats are becoming kind of standard issue on this campus. There's a lot of construction going on, and it's great. It's fantastic. Every day when I drive into campus and I see the cranes and the buildings going up, it sounds a little like hyperbole, but I do sort of stop and go, wow, because I've been here since 2004, and we've talked about growing, we've talked about doing it, and there are buildings going up everywhere. Just a brief overview here. You'll see some highlighted buildings there in yellow. Let's just walk through them real quick. First of all, for orientation, we are roughly right about here. We have our Discovery and Innovation building over on the research wing going in. This is going to house the new lung restoration center, but it's also going to house a floor for regenerative medicine research. And then the third floor will be something I'm kind of involved in now, and that's a bioincubator where Mayo's thinking more entrepreneurially about providing an avenue for our clinicians and scientists, but also people outside, to bring startup companies to help them take their idea, build a company around it, and get out into the economy. We have the Destination Medical Building, which I think you probably saw as you drove in. It's the one that's nearly complete. This is going to house new services for both oncology and neurology. We have the Cyclotron building, which in conjunction with our Mayo South expansion is going to enhance our ability around imaging. And you heard, I know Neil talked about it, and I caught the end of Sarah's. Imaging obviously is becoming even more and more prevalent in medical practice, and some of the technological advances around imaging are just amazing. We'll be prepared to push them into the practice with this new space. And then finally, the Mayo North expansion, which again is going to give us this expansion of these state-of-the-art operating rooms so that we can do more surgeries for people and help them. So, again, sort of the classic example of how fast things are moving is we have the Florida Destination Medical Building that is going to be opening in the fall, or summer or fall of 2018, and I have a feeling it's going to be closer to the summer. So things are happening very, very rapidly. This is something that was part of the plan, and it's already starting to happen. The building is going up. It seems like every Friday when I leave, when I come back in on Monday, the building looks just completely different. It's going to be a gorgeous building. So again, it's showing you the activity that's happening on the campus. But the final thing I'll say as I wrap up, and some of you that see me talk, I've said this before, another thing we're really investing in is innovation. We're realizing that innovation is key, and I've used this slide before. Even the mulch on our campus is apparently innovative. So it's a driving force here, and it actually comes from a mantra from a book that Dr. Ferrugia was part of authoring, Thinking Big, Starting Small, and Moving Fast. And this is something that sort of cuts across all of these areas. Is we're being asked to think big and then start small. Figure out how you can start to take that big idea and make some headway. But once you start doing that, move fast. Because we want to take these things that we're investing in. It's great that we're investing in them. But just like the building going up rapidly, we want to get them into the practice rapidly. Because the sooner we do that, the sooner we help people. Because changing healthcare, and again, I've used this slide before too, sort of feels like this. So the final thing I'll say, and this is probably the most important thing I will say in the entire 12 minutes that I've spoken now, is this takes partnerships. It takes partnerships within and outside of Mayo, and one of those key partnerships is our wonderful relationship we have with our benefactors. The ability to move quickly and think innovatively, think big, start small, move fast, is directly dependent on this wonderful, wonderful relationship we have with our benefactors. I've personally seen it with Dan and Cecilia in the Center for Individualized Medicine, how we are light years And that's, again, not hyperbole. Light years ahead of where we would be if we didn't have the wonderful partnership we do with them. So I'll finish off with something that's, what is today, Wednesday? It's midweek. We'll call it your inspirational thought for midweek. All these things we're doing, and I use this when I'm giving my talks about the Center for Individualized Medicine, but it goes way beyond that. It goes to everything we're doing at Mayo Clinic, how we're going to know we're succeeding. This is a quote about success and how you know you're making progress. When the unimaginable becomes the unremarkable, that's progress. And if you think about everything you hear about, whether it's Sarah, Neil, you'll hear from Dr. Q later, if you think about the things we're talking about that we're doing in the practice today, a few years ago were unimaginable. And let's take it out of research and practice for a minute. The thought that we would have 5 sort of consecutive construction projects going on at Mayo Clinic at the same time was unimaginable 5 years ago. And now, it's a little bit unremarkable. We're kind of like, yeah, this is what we're doing. We're moving fast. We're building. We're growing. So that's how we manage our progress or maintain our progress and success, is to really think about the things that a few years ago were just unimaginable, and now they've become unremarkable. So as always, thanks so much for your generosity and support. I don't know if they planned for there to be questions for me, but I'd be happy to take them, or if we want to get to lunch.
We certainly, if you have
Whatever you wanna do.
questions for Dr. Parker, if you want to know what shirt he eventually wore to the game, or any other questions, we certainly have time for that.
Yeah. And you don't have to write them down. We can do the unfiltered version. And if there are none, too, that's also. Real quick, while you're thinking of them, I do want to give a big shout out to Matt and Sarah. Matt put the slides together for me because I had like very little time. He did a fantastic job. I'm onto your trick, though. He gave them to me really late, so I didn't have a whole lot of time to mess them, but I did sneak one in there, Matt. So, and then Sarah for literally doing everything to make this easy, including bringing me hot tea yesterday because I was starting to get sick. So, thanks a bunch. Do any strategies permit more older patients with or without Medicare aspects, or is Mayo focused on specialists primarily? So the question here is, are any of these strategies permitting more older patients? You know, there's this notion out there that really being an older patient is somebody that people don't want to see, and let's just nip that right in the bud. This is about, we are focused on becoming the place where when people have complex, high acuity care, they need us. Our doors are open for them, absolutely unequivocally across the board. So all of these specialty areas are about making us, you know, the way I've said it before, if you have a runny nose, you don't need Mayo Clinic. Your local physician can take care of you. If you want to come, that's great. But if you need brain surgery, we want you to come to Mayo Clinic. So all these are being built around making access for people that need us available. Good question.
Any other questions?
Awesome. Yeah.
Well, we didn't find out what shirt he wore, but Carolina. Okay, good to know. Good to know. We have a short break now. You can get up and stretch, move around, and they will be preparing our lunch, but they'll be coming in as we get up and move around a little bit. So after lunch, we'll hear from Dr. Q, and I'll be glad to introduce him in a few minutes. Thanks. Hello again. We're going to resume. Dr. Alfredo Quinones Hinojosa, who is going to be Dr. Q, who will be with us in a few minutes, has gone to see a patient family. He's been in surgery this morning, and so he will be down in just a few minutes, but he wanted us to start with a patient video that he wanted to share, so we're going to start that now, and as soon as he gets down, we'll continue with a conversation with him.
My name is Alfredo Quinones Hinojosa. I am the chair of neurologic surgery. My role here at the Mayo Clinic is to take care of patients that have the most complex type of brain and spine disorders. When Cherry came to clinic, first of all, the first thing that I saw a young woman, age 40, and I saw this young woman with her husband, with 2 teenage daughters, and her mother, with a history of von Hippel-Lindau. Von Hippel-Lindau is a genetic condition, and some patients obviously develop these conditions where they run in their families. They tend to develop several tumors in different parts of the body. When it comes relevant to neurosurgery is when they develop tumors in the brain. But what Cherry had was a tumor the size of my fist. I saw a woman in a wheelchair because she couldn't walk anymore. I saw a woman that was beginning to have more difficulty controlling her daily functions, and I knew that she was getting into that situation where things were going to get more and more dangerous. She had undergone more than 9 surgeries prior to coming to us, and she had already a very aggressive round of radiation as well. So her brain couldn't tolerate many more things. But we knew, based on our experience and our multidisciplinary team, that her best choice of fighting for her life was to take her to the operating room, try to get this tumor out. And this is when I get Dr. Robbie Talk involved in this.
People with von Hippel-Lindau disease have typically tumor lesions that grow in a very uncontrollable way, and there is sometimes multiple of them, and they are very difficult to take out. So, 2 things.
One of the things that you have to consider about these tumors are the extraordinary challenges when you take a patient like this into the operating room. The first thing that you have to consider is that they're so vascular that at the moment that you go in, these tumors can basically explode in front of you, and then suddenly the field is saturated with blood and you don't know exactly what wires you're disconnecting, so you can leave the patient, completely incapacitated, unable to swallow, unable to breathe. Heart can stop suddenly in the operating room. So all those things are the risk associated with surgery.
We saw her problem to be challenging, and we got ready.
So we designed, Dr. Robbie Talk was going to go in with the small little catheters and inject the small nanoparticles that would allow the tumor to die from the inside out, deploying technology that only a few people in the world can do. But that actually came from the fact that we are familiar with that technology, that we get to use it in the laboratory every day. You have to be someone who is constantly working in research and in education and trying to use all that knowledge back into the patient.
Now, when it comes to surgery, what we did differently is we lined up a microscope and we worked with 4 hands together.
And we were able to come in and surround this tumor, and we were able to get the tumor out completely. The images show an amazing resection. The images show a dream, an amazingly clean cavity, despite of the fact that this tumor, like I said, was the size of my fist. She's beginning to walk. She's beginning to get out of her wheelchair. She is beginning to be cleared by physical therapy and occupational therapy at the rehab facility. She was shaking my hand. She had much better control of her legs. The fact that she's up and about tells me that she is just amazing.
After surgery is done, there is a lot of research. We analyze the genes, we take blood samples. This is essential because we're looking at how to fight this disease.
To me, what is inspirational is the fact that the knowledge that we have acquired through taking care of her are the tools that we are using and will continue to further develop, so that way we can take care of her daughters. One of them has a lesion, we're monitoring, no issues, and the other one is being tested. And we're using all those resources and all that knowledge at the Mayo Clinic to take care of the next generation. And I think that that's another reason why this story needs to be told.
I'm excited about the future because I have a future.
This has been a miracle to us.
It's just amazing to me.
They saved his life. That's what they did. I went through everything that I went through to build the person that I am today.
You know, we feel like they gave her a second chance, but they gave us a future.
I was up and walking the halls the same day I had the operation.
That was a super shot, Lou.
It was like a new lease on life.
It's an amazing gift that I'll never be able to repay.
This place is beyond amazing. They gave me a second chance. You know, they saved my life.
And I look forward to you getting to know him through a series of questions.
Thank you.
And I love that we have these chairs that make us feel like kings and queens.
I want to take him home.
Me too. Me too. Dr. Q, tell us how you became interested in medicine and neurosurgery.
First in medicine. I think most people know I grew up in very humble beginnings in Mexico, not even in Mexico City, in a small state called Baja California, which is down south from California. Within that state, there's a small town called Mexicali, and outside of Mexicali, about 60 kilometers down south, it's a small little farming community. They're literally small, like 300-400 people live in these places. That's where I grew up. It's called Ejido, Sinaloa, and my grandmother, we used to call her Nana Maria, she was a town healer and a midwife. And it was called curandera. Those are the people who learn how to deal with herbs and stuff. And despite of us growing up in that small little community, she basically had a destination medical center. Because there were people, it's interesting because this is the first time that I thought about that, because we're a destination medical center. She had people coming from many communities, as far as the state next to Baja California, because she was known to be the best midwife known. She delivered thousands of children, and she was unbelievable. And she had, even though she never went to school, she had a lot of understanding of medicine, but more important, she knew how to treat people, and people loved her. Now, she was not an easy person, I tell you, because she's the one who really put a lot of sort of metrics in my life when I was growing up, because as you can imagine, I got into a lot of trouble when I was a kid. I was full of energy and running around, so she was the one. So that's how I think. As I look back in my life, I started getting used, thinking about medicine, but I didn't know. If I tell you that I knew I was going to go into medical school or medicine, I had no idea. I came to the States when I was 19 years old as an undocumented migrant farm worker. I worked in the fields of California, up in Northern California, in the San Joaquin Valley. Eventually, that was in 1987, I was 19. By 1988, I was going to community college to learn English. And by 1989, I was in a community college learning English and trying to do my science. And I got accepted 2 years later into the University of California, Berkeley. That's where I began to ask myself, what's going to be next? By 1990, I really didn't. I've been there, but by 1992, in 93, that school year, I wasn't quite sure. I've been there in Berkeley doing science. And then my maternal grandfather died. So I had to go back to Mexico, and I took a long trip. And I was really not clear what my path was going to be. And I went back to my roots about caring for people. And I thought about my grandmother, and I said, you know what? I had no idea what medicine was all about. I said, medicine is going to be. And I also didn't know that I had the grades to go into medical school. So that's how I got interested in medicine. And next thing I know, I UC Berkeley, I get accepted to medical school. And here I am, taking a flight from California to Boston to go to Harvard Medical School. So I got accepted into Harvard. I'm sure that the grade point average was severely compromised when I got accepted downwards. No, I'm just kidding. But I got accepted, and I ended up doing my medical school. And then the second part is the issue of the brain. You guys saw the video, obviously, with Sherry. And it's an amazing story. I mean, these are the true unsung heroes. I thought about brain surgery, and I've been so blessed in my life. The greatest blessing that I have had in my life is obviously my wife and our children, but also the fact that our patients, many of you put your lives and your loved ones in our hands, and that is a tremendous privilege that I take very seriously. So I ended up seeing my first awake craniotomy. I walked into the operating room on a very late Friday night. A surgeon sees me on the hallway heading out to the Conway Library at Harvard, and this was at the Brigham and Women's Hospital, and he pulls me over, and he introduced himself to him, and I knew exactly who he was because a month prior, he was on the cover of the Harvard magazine, and he was a very well-known brain surgeon. And he said to me, "Hi, I'm Peter Black." And I said, "Hi, I'm Alfredo." He asked me, "What's your name?" I said, "I'm Alfredo Quinones." He asked me, "Have you ever seen brain surgery?" And I said, "No." I said, "Would you like to see brain surgery?" I said, "I'd love to." Thinking this Friday night, 11 p.m. He goes, "Let's go." He get me a set of scraps like this, and here I am in the operating room. I remember going in and my knees buckling because the brain was going like this. And the patient was talking as we were doing this. Guess what I was doing this morning? Exactly the same case. This just right now, this morning, a physicist, a doctor who's amazingly bright, and he did a beautiful job in the brain. And after that, I went home and I told my wife that I had fallen in love with the brain. So I was clear about that.
So what about the transition to neuro-oncology and brain cancer?
So as I look back in my life, I went into residency. I got accepted at the time. The top residency program to train in brain surgery was at the University of California, San Francisco. So by 1999, when I graduated from medical school, they took me, and I remember I saw many patients. And at first, I thought I was going to be a spine surgeon, which is amazing. The spine is beautiful, it's complex, and I fell in love with the spine. And then I went on to see vascular neurosurgery, where you take care of problems like this with little vessels and aneurysms and catheters, and extraordinarily complex. But then, here I am as a third-year resident, and one day, a young man is accepted into the emergency room in Oakland, and he gets transferred to us. And it turns out that he was a UC Berkeley student who suddenly had a massive seizure. And his initials are J.O. I read about this. It's been on the news. And he gets transferred to the University of California, San Francisco, and his parents didn't speak English. They were migrant farm workers, and he was the first one in his family to go to college. And I was the only Spanish-speaking resident at UCSF. I was actually the first one to be trained in California system from a Mexican-American background. And I got assigned to take care of him. And I saw how this disease took not only the best of him over the next year and a half, because brain cancer, we all know, that is the most devastating disease that affects the most beautiful organ in our body. And my heart was just, I was assigned to take care of him and his parents, and I saw how he was the hope they had that someone in their family was getting an education, and I saw from beginning until he passed away secondary to this cancer. And I related to, because I had come to this country as a migrant farm worker, and I related to his parents because they were my parents. So I saw myself into this. And then I went on to tell my mentors that I was interested in brain cancer, and everybody was against it. Literally, they say, you have so much talent to do vascular neurosurgery, to do spine, to do many other things. People have failed in trying to find a cure for brain cancer for 100 years plus, and you're going to waste your career in trying to do it. And I just could not do it. I felt that it was my responsibility and my duty. So that's how I ended up doing this. And that's what I'm here with you guys, because I really do believe that what you do to help people who are in need through your work, through your, support of the Mayo Clinic is so crucial for people to give them hope, to find cures, to build bridges.
One of the things, if you ever get an email from Dr. Q or a voicemail, oftentimes he's not saying, well, see you tomorrow or do this project. He's saying, help me change the world. And I thought maybe you could talk about changing the world, your mission, and whether you think it's possible to cure brain cancer.
I thank you for that wonderful question. So I was telling Mr. Davis that I was in Mexico. Sunday night I went there. I was scheduled to bring a large group of people, many of our own surgeons from the Mayo Clinic. This is separate. This is a foundation. It's a non-for-profit called Mission Brain, BRAIN, Bridging Resources and Advancing International Neurosurgery. And I've been doing it since 2006, although the foundation became 501c3 around 2011. And we've done over 120 surgeries around the world. These are not simple surgeries. These are the surgeries like the one that I just did this morning where I had a team of about 25 people. So these are massive surgeries. And I do believe that we do have a responsibility, I believe, to build bridges, give hope, and changing the world. And I do believe that we can change the world. So I was there, and there's no one who can keep you more grounded, at least in my life, than my own children. I tell the story of David, my son David, who's 16 right now. When he was about 12 or 13, he said to me once, Dad, you know a lot about very little. But that little that you know, you're very passionate about it. It's true. I mean, my mom thinks because I went to Harvard Medical School, and probably most of you guys think because I went to a great medical school, I know a lot about medicine. But the reality is, I know a lot about the brain, And my son, same son, says to me one day, Dad, so is it true, this was about 2 years ago, is it true that they're going to make a movie about you? I said, yes, son, what do you think? I said, so who do you think is going to play your role? And I said, this is it. I'm going to play with him, with my own son. I said, I'm going to see how he reacts to this. I said, I don't know, son, but they're talking about, they want to make this movie realistic. I said, so they want a very tall man. Most of you guys know that I'm 5'7" with cowboy boots. So they want someone really muscular. Most of you guys can tell that I'm not that muscular. And really good looking. And my son, and I said, this is it. Son, they're thinking about Dwayne "The Rock" Johnson. Everybody's seen him. He's like about 6'4". And my son laughs a little bit. He goes, Dad, you're so passionate about what you do. I think the actor who's going to play is going to be Danny DeVito.
Oh.
But I relate that because of changing the world, because my daughter, luckily I have a daughter who thinks of her father much more than my own son, says to me one day, she's very, very philosophical. She says that we are not, because the foundation started with our children. We began this with our children. The little bit that we had, my wife and I, when we didn't even have furniture, I got a gift of $15,000 to the American Medical Association. And then back in 2010, that's the money that I used to bring the first group of surgeons with me to pay for their flights and stuff, because these things are never volunteer. And my daughter came for the first time. There's a big documentary that is coming out. Most of you guys don't know, but there's a big company that followed me for 6 years total, that they're releasing a documentary right now. They're going through the situation right now with Disney, because Disney is the one who owns the rights to my life and Plan B right now for making this movie. Plan B is made 12 Years a Slave, Big Short, Selma, and this year Moonlight. 2 of those movies had won an Academy Award, and all 4 have been nominated. So my daughter says to me, Dad, we are not what we have. We're really defined by the things that we do to change other people's lives. And she says, and I do vote for Dwayne "The Rock" Johnson to play your role. So I said, that's my girl. That's how I knew that she had good judgment. But I do believe that we have an opportunity to change the world, and that's how I feel about this.
How important do you think philanthropy is to curing brain cancer, treating people with brain cancer across the globe, and advancing the work that you and your team, and you brought a big team with you, the work that they're doing?
I do believe that we can do this. We all have a small little role to play, and some of us, many of you, have a much bigger role to play on what you do. there's no question in my mind that Mayo and many other institutions wouldn't be where we are today in finding cures, not only for brain cancer, but for many other cancers, finding cures for many other neurological disorders, many other GI problems, many other neuromuscular disorders. We wouldn't be able to do it if it wasn't for the support that many of you guys give through your philanthropic efforts to find cures. That's really the reason in my mind why the United States is at the forefront of finding cures, giving hope, building bridges in the world. And I do believe that we have a very philanthropic society who believes that we can actually change the world. The NIH money that we have, I feel that it is important. It is part of our responsibility as society to put peer review groups of people who will somehow guide some of the research being conducted. And I serve at the NIH. I myself have several grants through the NIH. I know that, I think I saw Geraldine somewhere. Ms. Ferrugia, right? I see. I know Janrico has. Most of you guys may not be aware. He's the only CEO that is NIH funded. That is great to put the seal of approval that what we do is peer review and is important. But it's only one small little portion of the amount of money that we need and the resources that we need to really find cures for different diseases. So I obviously am very grateful for many of you guys for the support that you guys give to the Mayo Clinic. I believe in the Mayo Clinic. I love the Mayo Clinic. I've been here for a little bit over a year. September 5th was this anniversary of my first surgery here. I was blessed to be recruited by all of you, by Janrico. I am extraordinarily grateful for the support that many of you guys give to the world through this vehicle, which is the Mayo Clinic. I think that only then, combining the federal support through the philanthropic effort of many of you, only then we'll be able to change the world.
Dr. Q, what attracted you to Mayo Clinic, and why do you think it's the place that you need to do your work now?
I think for me it was very simple. So I had already looked several places throughout the United States, very good places, very strong academic medical centers. But I was already at a very good academic medical center, which is Johns Hopkins. Everybody knows, a great place. You know, they're great research, great education, and good patient care. I say good patient care. There's only one place that I knew. I told my wife already, we had given up a lot of opportunities. When I say we, she's the one who made the decisions. I mean, I just went and interviewed, and then I said, what do you think of this place? No, everything, no. So I said, around 2015, I said, that's it. I'm not going to look at anything. We're going to spend the rest of our life here at Johns Hopkins. And then I put a disclaimer, except if one day someone asked me to go to the Mayo Clinic. And she laughed. She thought I was, that's not going to happen. And sure enough, like a few months later, I was asked to come up and look at this job, and I came, and I kid you not, I walked into these hallways, into the hospital. I met many of you, and just the way I felt about the brain back in 1997 when I felt about this place. But now, I needed to convince the real boss. Everybody knows who the real boss of my house is. So then we came, and obviously Anna and the kids fell in love with the area. She is in love with the place. She gets her care here. So when it comes to patient care, which is at the front of what we do in the Three Shields, this place, I tell you, is unmatched. No other place in the world compares to this place. And that, to me, is the essence. The research and the education that we do is extraordinarily crucial and important because at the end, we want patients' care and their quality of life to be the best there is. And that's what this place exemplifies, and that's how I feel about this place. And it was a no-brainer, as I tell people. Once I saw that and Anna was convinced, it was no-brainer.
Good. Many of these people probably haven't seen you or heard this story before. Could you tell us how many people you brought with you and how many since have joined your team?
I normally don't say this in front of Hopkins because everybody jokes around that they're a little bit, they're disappointed, not because I left, it's because the group of people that came with me. Yeah. So we brought all together between the laboratory, faculty, the international office, and a few more recruits that we just did this year. We brought in anywhere between 27 to 28 people, plus dogs, cats, children, and everything else. I myself brought 2 dogs and 2 cats. They were part of the lab too there, but that's not counting them. So it was an amazing number of people. People say, wow, did they follow you? And I said, no, they didn't follow me. They follow a dream that we had together. The same dream that you asked me about, can we change the world? Can Mayo change the world? I think Mayo can change the world, not because we are Mayo, it's because we are all of you, because we are all together on this dream of making this world a better place. And that's why, because you gather today, you break bread, you talk about the advances that are happening. This is why this place can change the world. So we built a dream. And so I came, and I also asked the different leaders in my lab, the different faculty, come and check it out. If you think I can't move alone, and Gianrico, I remember when I talked to Gianrico on the phone, I said, Gianrico, if you want me to come back, I don't work alone. I'm only as good as the rest of my team is. I'm only as good as in a chain. Each of those, chain pieces are important. And I said, if they want to come, then we'll all come together. And sure enough, I brought a group of 5 people representing all different groups, and they all loved the place. So I wasn't the only one. I fell in love with the place, and I wanted to see how they felt. And they all unanimously decided to move, and we moved all their grants, and here we are in the new laboratory that you guys built for us, and now we are trying to find cures with all of you guys together.
Great. It's a pleasure to talk to you today. I knew some of that story, but I continue to hear things I haven't heard before. It's also nice of you to tell us that if we have a foot problem or a skin problem, we shouldn't be coming to you. But if we have brain cancer, that this is the best place to come on the planet. And it's nice to be able to say that. Is there anything else you'd like to share with these new friends today?
No, I am delighted, obviously, to be here with all of you guys. I know that we have a few minutes for a few questions. I'd be delighted to answer any questions, medical, non-medical, whatever it may be, personal, non-personal. My life is an open book. Right here we have the first question. It's an open book. I read in a book. I'm actually do work. One last thing, I'm working in a second book. This one is going to be published by Disney. I am so excited. I know Gianrico read it already. I know Geraldine read it already, part of it. So I'm working on this book. I'm hopefully that you guys, I'm hoping that you guys will enjoy it when I publish it next year. It's an oligodendroglioma operable. And the short answer is yes. Was this your question? Is that yes? So the answer is absolutely. I will tell patients, we see here in Mayo a lot of patients that are told you have an inoperable tumor. Some of them are truly challenging to operate, but I would say no tumor is inoperable. The question becomes, what is the potential collateral damage, and what is the expertise of a team to be able to tackle that tumor? Like this morning, if you went into the operating room, you saw Dr. Pamillas, who is one of our fellows who just came from Puerto Rico, by the way, talking about Puerto Rico and struggle with her family there, so I just want to make sure that everybody sees her. But we were working together. I said, you're like a director of an orchestra. You need about 20 people to make sure that that song is perfect and everything goes very smooth. But you have to have the expertise, the anesthesiologists, the nurses, the actual neuromonitoring. So there's all together. You got to have expertise in all single areas to be able to do this tumor. So an oligodendroglioma is known that it's not only operable, some of them, if the extent of resection is very thorough, then you can potentially achieve a long-term cure for these patients. So, thank you for the question.
Other questions for Dr. Q?
They're postprandial.
Well, I know you'll be glad to answer questions from them as you're leaving today. Exactly.
I'd be delighted to.
Dr. Q is our final speaker today, and I want to end by thanking you for coming. Your support makes Dr. Q's work and the work of all of our physicians and scientists from whom you've heard today possible, and we're deeply grateful. You may know that this Behind the Shields event is part of a series. The next event is scheduled for Arizona, so if you're going to be in Arizona, or if you're online and going to be in Arizona, we hope you'll attend that event. Before you depart, we hope you'll fill out the evaluation that's in your packet. And if you had a question that was not answered or you were too shy to ask, please hand it to one of us, and we'll be sure it gets to the physician or scientist and get you an answer. And make sure if you're going to do that, your name is on it and a phone number so that we can get you an answer. Thanks again for coming, and we look forward to, if you have, Sarah's my helper, and let's give a round of applause to Sarah. Sarah plans events for us, and she does a wonderful job, and she keeps people in line. She keeps me in line. That's more important. If you have a sticker on your folder, that means of your folder, please take the flowers with you today.
Wow. I don't have a folder.
I'm sorry. Thanks again. Thanks again
Thank
for
you,
coming.
everybody. Have a great day.
Thank you. Perfect. Thank you. That was great.